Dear colleagues, this is Mohamed Abd Elbasit, lecturer of cardiology at EgSC University. I'd like to welcome you in Peripheral Art section in Cardiac Academy Mentorship Program 2020. Peripheral Art disease topic is adopted from 2017 EgSC guidelines on diagnosis and the treatment of peripheral art disease. The first most important thing the guideline focused on is multidisciplinary vascular team for the best decisions for management of patients with peripheral artery disease. There are many topics under the umbrella of peripheral artery disease, starting with cerebrovascular disease, carotid artery disease, vertebral artery disease that present with central manifestations such as stroke, upper extremity artery disease that present with subclavian-steal syndrome or acute ischemia, mesenteric artery disease that could present with acute or chronic mesenteric ischemia, renal artery disease that is frequently encountered in young patients with hypertension and renal impairment, lower extremity artery disease, which is the most frequent form of peripheral artery disease presenting with acute or chronic ischemia. Evaluation of patients with suspected peripheral artery disease should involve family history of cardiovascular disease and the premature cardiovascular disease, which is fatal or non-fatal cardiovascular disease events, or established cardiovascular disease in first degree male relative below 55 years old or female relative below 65 years old. You have to make your own checklist to check for hypertension, diabetes, dyslipidemia, smoking, chronic kidney disease, sedentary life, dietary habits, history of cancer and radiation therapy, and psychosocial factors and prior cardiovascular disease. You have to check also for neurological symptoms, arm pain, and any symptoms suggesting angina and dyspnea. Abdominal pain could be a symptom for intestinal angina and the mesenteric occlusions, particularly if related to eating. Walking impairment and the claudications should be addressed against type, location, timing, and distance. You have to check for wrists, lower limb pain, poorly healing wounds of extremities, and functional capacity and erectile dysfunction. Physical examination for patients with peripheral artery disease should involve auscultation and palpation of cervical and supracervical areas, careful inspection of upper extremities including hands for color and integrity of the skin, palpation of upper extremity pulse, blood pressure measurement on both arms, auscultation for flanks, preumbilical region and groin, and abdominal palpation and the peripheral pulse palpations. Careful inspection of lower limb, especially feet, for presence of signs of dystrophic changes associated with chronic limb ischemia, and you have to examine for peripheral neuropathy. Lab assessment for patients with suspected peripheral artery disease should involve fasting blood sugar, fasting serum lipid profile, serum creatinine and creatinine clearance, urine analysis for microalbuminuria, and blood count and uric acid level. If the patient has impaired glucose tolerance or fasting glucose more than 101 milligram deciliter, you have to ask for glycated hemoglobin. Lipoprotein A should be ordered for patients with family history of premature cardiovascular disease and to quantitative proteinuria if positive dipstick tests. Ankle brachial index is a bedside test. Have to be ordered for patients with clinical suspicion of lower extremity artery disease or patient at risk of lower extremity artery disease, or even asymptomatic individuals aged more than 65 years old or below 65 years old but at high cardiovascular risk, or below 50 years old with family history of lower extremity artery disease. How to measure? You have to check for the systolic pressure in both legs and arm using Doppler probe 5 to 10 megahertz. After that, you have to divide the ankle systolic blood pressure by the brachial systolic blood pressure. The normal value between 1 and 1.4. Below 0.9 it is abnormal low, and above 1.4 it is abnormal high. Low values carries higher risk. General recommendation for patients with peripheral artery disease include smoking cessation, healthy diet and physical activity, statins, which is class 1 for patients with peripheral artery disease, and the targets of LDL according to the recent guidelines in 55, not 70 as in previous guidelines. 55 milligram per deciliter, as the patient with peripheral artery disease is classified as very high risk of cardiovascular disease. In diabetic patients, strict glycemic control, you have to make hemoglobin A1C less than 7. Antiplatelet therapy is recommended for patients with symptomatic peripheral artery disease and your blood pressure target below 140/90, and the recent guidelines, I think it recommends below 130/80. ACE or ARBs should be considered as first-line therapy in patients with peripheral artery disease and hypertension. As regarding use of antithrombotics in patients with carotid artery stenosis, if asymptomatic, just single antiplatelet therapy, aspirin or clopidogrel. If carotid artery stenting, you have to go for dual antiplatelet therapy for 1 month, then single antiplatelet therapy. After carotid surgery, single antiplatelet therapy. In patients with lower extremity disease not requiring anticoagulation, asymptomatic patient, it is class 3 to prescribe antiplatelet therapy. If symptomatic, single antiplatelet therapy. After percutaneous revascularization, DAPT therapy for 1 month, then single antiplatelet therapy. After surgery, you have to choose between single antiplatelet therapy or vitamin K antagonist monotherapy, and both are class 2B indications. Regarding patients with lower extremity artery disease requiring oral anticoagulation, if the patient is asymptomatic, symptomatic, or after surgery, oral anticoagulant therapy is recommended. After percutaneous intervention in patients with low risk, you have to go for dual therapy for 1 month involving oral anticoagulation. After that, you have to choose between oral anticoagulation alone or oral anticoagulation with 1 antiplatelet therapy, which is class 2B indication. After percutaneous intervention for patients with high bleeding risk, you have to go for oral anticoagulation monotherapy. To remember, we have many forms of peripheral artery disease ranging from central cerebral vascular disease and lower extremity artery disease. Looking forward meeting you in Egyptian Heart House on 20 February 20 and 21, and thank you.